introduce Amit Sharma for our first talk. Amit is a native of Grand Forks. He went to med school in North Dakota. He's been a resident here at Abbott Northwestern, and he approached me towards the end of his residency program looking for a research project. So we were happy to get him involved in our aortic dissection program, looking at the data on long-term outcome. This has really been a collaborative effort with our imagers, with the cardiac and the vascular surgeons. So, and you'll hear more about our program in December. But Amit, want to present your data? And this is a poster. Okay.
All right, well, good morning, everybody. Thanks for joining me here on this Monday morning, and we'll get started. So thanks, Dr. Harris, for that introduction, and most importantly, all your help with this project and responding to my very regular weekend emails. So we're going to get started. So the title of my talk here is Adherence with Guideline Recommended Follow-Up Care is Associated with Improved Survival in Aortic Dissection. I have no disclosures related to this talk. So just a little bit of background. So as many of you know, patients that present with an acute aortic dissection, not only do they have high in-hospital mortality, but those patients that survive the acute event are at high risk for long-term complications down the line, some of which we'll talk about. The general management strategy for a type A aortic dissection, which I'll go into in just a second here, is really surgical. And looking at type B dissections and uncomplicated type B dissections, medical management has kind of been the mainstay of therapy. And with complicated type B dissections, this is where interventional, endovascular, and surgical therapies are instituted. So based on ACC and AHA aortic guidelines, patients that have an aortic dissection event and survive the hospital discharge are basically followed up in the clinic with imaging follow-up at 3, 6, and 12 months, and then annually thereafter in the absence of any complications or other things that would require more frequent follow-up and imaging. So at MHI here, we have an aortic dissection program that's kind of designed basically to look at these patients and try to do our best to get them back to clinic, follow-up imaging to ensure that we're picking up people that are progressing and intervening before they have unforeseen complications. So that's really kind of the goal of this talk. And this is just a picture just to kind of give you a quick review of the anatomic discussion here with the type A and type B dissection. So the top two images to the left of the screen are type A aortic dissections. That's Stanford classification, and those are essentially involving the ascending aorta and or the aortic arch. And then to the far right, there is our Stanford type B dissection, which is really anything that involves the descending aorta only, without ascending involvement. So as I kind of previously touched on, so the objective of this study was to look at whether our aortic dissection center and follow-up protocol has any bearing on outcomes related to the patients that we see moving forward following their acute event. So methods, we looked at all of the patients that were admitted to our aortic dissection center here at MHI since 2004, and really patients that gave us consent to participate in research. We analyzed these patients from basically the index hospital admission and followed them long-term for basically adverse outcomes. The definition of hospital death, which is fairly consistent with most other aortic dissection studies, is hospital death being defined as anything from the admission to within 30 days of the date of admission. And the way we chose to analyze whether our compliance really had any bearing on outcome was we broke them up into 3 groups, and the breaking up was somewhat arbitrary. It was mostly to help with kind of data analysis. This isn't based on any particular guidelines, but we broke people up into 3 groups of follow-up, low, medium, and high. Low is defined as less than 33% follow-up with clinic appointments. Medium was 34 to 67%, and then our high follow-up group was over 67%. We defined compliance with blood pressure, which was one of the variables we looked at based on the AHA definition of less than 140 over 90 millimeters of mercury following an aortic dissection event. And the way we kind of did this was we took all the blood pressure values that patients had at their follow-up appointments and averaged them to come up with basically a composite blood pressure, and that is what we used. And then as the last slide here, or the last bullet says, we looked at clinical and demographic variables to see if there was any bearing in terms of outcome for these patients. So just a picture here, a pie graph that kind of breaks up our patients into their various compliance groups. Here to the top left, this is our high compliance group. There's 64 of our 160 patients were in this group. Intermediate is down here at 46 of our 160 patients, and then to the top right, in the darkest color is the lowest compliance group. There was 50 patients there. So this is one of two tables here that just kind of looks at the basic demographics. So the column to the left is all of our patients, 160 total that survived the index hospital admission. And then the following three columns basically break up their characteristics based on their adherence group. And for the most part, our patients were fairly well matched. The one thing you'll see that I have bolded is diabetes. There was a higher percentage of patients in the low compliance group that had diabetes that met a statistically significant value. But in terms of, male, percentage of smokers, other modifiable risk factors such as hypertension, hyperlipidemia, it's not on this slide, but we did look at demographics as to what type of insurance they had, whether they were married, kind of all those things, and really none of those things were found to be significant. Additionally, our Marfan syndrome was looked at. That was not significantly different between any of our follow-up groups. And then at the bottom, you can see we actually looked at patients as to where they initially presented. So this didn't reflect the change. This thing that says PCI hospital should be AD center, so I will be sure to fix that for next week. Zone 1 was defined as basically 0 to 60 miles away from our center, and then Zone 2 was 60 to greater miles, essentially. And looking at the three different groups, there was really no major difference in whether patients that were not compliant or were compliant, where they were coming from. This table continued. So we also looked at the different groups in terms of their dissection type, how they were managed, whether that was medical, surgical. There was no difference there. The third line you'll see is the beta blocker. And patients that were more likely to follow up in the medium and high group had higher usage of beta blockers than those that were in the lowest compliance group. And you'll also see angiotensin receptor blockers. Interestingly, the intermediate compliance group had the highest usage of angiotensin receptor blockers. In terms of looking at really average follow-up across the cohort was really 53%. So people kind of show up as a whole to about half of what they should be doing. And I think the important thing that highlights is we still have some work to do to get these people back. No major difference in terms of adherence with blood pressure goals between the two groups. And I think the most important part of this, which we'll talk about, is looking at 5-year survival for these patients. The patients that were in the intermediate and higher groups of follow-up had statistically significant improvements in survival compared to the group with the least follow-up. So this figure here basically just shows our overall age-adjusted survival, excluding in-hospital death of type A and type B dissections. And this is kind of similar to a lot of the data that has come out. So the general thinking is type A patients do worse initially because of higher in-hospital mortality. And type B patients generally do better early on. But as you can see, kind of right around the 4.5, 5-year mark, the curves start to cross, where actually type B patients moving out past the 4 to 5 year mark actually have, based on our cohort, worse outcomes in terms of survival, even though it didn't meet statistical significance here, comparing type A and B dissection. But that's something we're seeing, and so I think it kind of highlights the importance of finding these type B patients and following them very closely for long-term complications and things that would predict poor outcome. And this is a similar slide, but basically breaks up survival of our 3 different cohorts. And The line at the bottom, which is the darkest line, is clearly our lowest follow-up group, and they had by far the worst survival. And then when you look at the red line, which is our intermediate adherence group, and then our green line, which is the highest compliance group, and they clearly had better outcomes than the lowest compliance group. So the point with this is that following up, coming to clinic, having us take pictures and follow things closely actually has translated into a survival benefit for our group of patients. And so this is a table that is basically a multivariate analysis. So we found 3 things that were predictive of poor outcomes. So age, the older you were, the worse you did, which is probably not surprising. Smoking was statistically significant with a hazard ratio of 2.4. And then at the very bottom, both, as I previously mentioned, the intermediate and high compliance groups had statistically significant improvements in survival compared to the low group. So to go through this once again, of our 160 patients that survived through a hospital discharge, we followed them closely. In terms of baseline variables, they were a fairly well-matched cohort in terms of most of our risk factors and medication usage, other than the diabetes, the beta blocker, and the angiotensin receptor blocker we talked about. The fourth point here, those 2 medications were used more frequently in patients that were more compliant with follow-up. We did not find a mortality benefit with the use of those medications on multivariate analysis. So that's I think there has been some data, of course, in the past that said some people do better with beta blockers and some that have shown there's really not much of a difference. And the independent predictors of mortality were age, smoking, and compliance with follow-up. So conclusions and implications for this moving forward. So the patients that present to our center and are followed closely generally do better than those that aren't coming back to appointments. And the patients that had the lower compliance, I mean, they just did worse. So that's, I think, the biggest take-home point for this. And implications for things moving forward is that if we can increase compliance with folks coming back to clinic, we have a special program here where we have multiple people that will call these patients that aren't coming back for their clinic appointments, for their CTs, things like that, as an effort to increase compliance. That is going to be an important thing moving forward.
Nice job, Amit. I'm going to roll my job down this data and putting it together. Great work. So you define follow-up at 3, 6, and 12 months, right? Mm-hmm. So if somebody died during the first year, did you censor these patients? And I wonder if you exclude the first year, somebody died, they're not going to follow up. What would there be statistically different survival in year 1 to 5?
Yeah, it's an interesting thing because we looked at it from statistically significant survival at 1 year. I didn't present that data, but there was also statistical significance with follow-up compliance. And when we looked at the overall cohort, the patients, the type A and Bs had roughly low to mid 90% survival rate at 1 year. So I think it's an interesting thought. I think most of our patients that survived the index admission did survive to 1 year. So I think I don't know how much of an impact that would have, given that both groups had pretty good 1 year survival.
The graph showed that those who didn't follow up had less survival so at 1 year.
Right.
Did you relate compliance with follow-up to the zone of transfer and where the patient lived?
So we looked at the zone of transfer, and there was where patients came from, and there was no statistically significant difference in terms of compliance with follow-up, defined as where people were coming from initially.
Very nice work. What about follow-up really makes the survival higher? Patients get an operation, or was it that the patient already lost the follow-up, didn't follow up because they died before the follow-up period? I'd be curious to know what exactly about follow-up in these patients.
Right. So we looked at reintervention across the 3 different compliance follow-up groups, and there was no difference in the number of reinterventions. So one of the thoughts, kind of like you said, was maybe people were having more, follow-up operations and interventions, and they were actually doing better from that standpoint. We didn't see that here. So I think that was one thing that we very specifically did look at to make sure that wasn't the case, is that more surgery down the line were the reason people were having improved outcomes. One thing we did talk about was, perhaps there's something in our patients that certain groups of patients that we see as higher risk, perhaps based on initial aortic size, comorbidities, that maybe we're reaching out to them more frequently to try to increase their compliance with follow-up. And so in a way, the people that are compliant with follow-up, we're almost kind of selecting them out because they're higher risk in the first place. So that's something that we'll look at as well moving forward.
But to be clear, the compliance rate stops when you die.
Right.
You look at the compliance of if you die before you die, you look at how often you come to the clinic before that. This is the last question. So you looked at the statistics?
We did. I didn't put that up here just because there was a lot of things we looked at, and that was not statistically different across the three groups.
Okay. Did you look at outcome difference in terms of underlying etiology, like for instance, underlying clinical disease or something like that? How many of these patients got the genetic testing?
So I don't know the question about how many patients had genetic testing. We did look at, I think we had only one patient that had Loyd-Dietz syndrome. We looked at Marfan syndrome across the three groups, and there was no difference in the amount of patients that across the three compliance groups that had Marfan syndrome. So that was not associated with survival in our group.
All right, thanks. Great job. So the next presenter is Dr. Angie Lobo. This is going to be a moderated poster. I think a lot of us know Angie, who is a Abbott Northwestern resident. She did her medical school in Costa Rica. She is married to one of our very accomplished former cardiology fellows, Dr. Sandoval. She worked with Dr. Barry Marin for a year before joining the residency program, and since she's joined, she's been working with Dr. Sharkey and Dr. Gray and has presented a number of abstracts really around the world on this work on spontaneous coronary dissection. Angie?
Thank you, Dr. Harris, for that introduction. Thank you all. I have a pleasure to be here presenting on behalf of my co-authors. So our poster for ATA is a moderated poster, and it's titled Revascularization Strategy and Subsequent Outcomes Among Patients with Spontaneous Coronary Artery Dissection that present with SC elevation myocardial infarction, and this is a multi-center U.S. registry. So these are our authors, and we have no disclosures relevant to this presentation. So spontaneous coronary artery dissection is an increasingly recognized cause of acute myocardial infarction, coronary syndrome. Most commonly, it does affect young women and middle-aged women without previously known atherosclerosis. It has been said that there's a conservative management approach proposed for these patients. And really, this approach may not be necessarily the most appropriate one for these patients who present with SC elevation myocardial infarction. So this approach led us to our study objective, which was to describe the revascularization strategy, the subsequent clinical outcomes in patients who present as SC elevation myocardial infarction due to SCAD. So our study is a multi-center, prospective, observational cohort study. It's done between a collaboration between two centers, the Minneapolis Heart Institute in a span of 14 years, and Cedars-Sinai Medical Center in a span of 7 years. Our population were patients who presented with STEMI within 24 hours of symptom onset. They presented for consideration of PCI. We examined baseline characteristics, the choice of revascularization, and clinical outcomes at 1 year with STEMI due to SCAD. So our entire cohort is 5,208 patients. We excluded 910 patients without appropriate follow-up, leaving us with 53 patients with STEMI due to SCAD and 4,245 patients with STEMI due to atherosclerosis. Our results are as follows. Mainly 93% were female and significantly younger with a mean age of 49.4. Also, all the other conventional cardiovascular risk factors, as you may think, they were also lower in this population, such as hypertension, hyperlipidemia, diabetes, and smoking status. When we further compared two groups, the ones who underwent revascularization and the ones who did not receive revascularization, we had no significant differences between baseline characteristics. Here, we can see that 19% of patients who presented with STEMI due to SCAD presented with cardiogenic shock. 74 of these patients underwent revascularization. Here, when comparing again revascularization group versus the non-revascularization group, we can see that 26 of them presented with cardiogenic shock who underwent revascularization, and 15% of them requiring circulatory support. From the revascularization group, 90% of patients underwent percutaneous coronary intervention, and 10% underwent coronary bypass graft. When we look further into coronary anatomy, the left main was involved in 13%. And here I want your particular attention. 13% in those patients who presented with STEMI and SCAD had left main involvement. Whether you see STEMI due to atherosclerosis, only 1.2% had left main involvement. The vast majority of patients, 47%, had LAD involvement against 38% in STEMI due to atherosclerosis. Looking into dissection location, here's particularly important that the vast majority had non-distal involvement, including mid and proximal. Here, again, when looking into revascularization versus non-revascularization, we can see the same characteristics. 44% of patients had LAD involvement and 18% had a left main involvement. The same distribution was here apparently. It was 39% mid involvement, 41% proximal. Again, 61% of these patients who did go under revascularization had a TIMI flow 0 to 1. And interestingly, 89% obtained and achieved a TIMI flow 3 post-procedure. So STEMI patients due to atherosclerosis required multiple stents. 37% of them required more than 2 stents, when compared to 83% of patients with STEMI due to SCAD needed more than 2 stents. So looking into for our outcomes, we examined in-hospital 30-day and 1-year all-cause mortality. Among patients with STEMI due to SCAD, there was only 1 death in our whole cohort, corresponding to 1.9% of patients with STEMI due to SCAD. This death occurred within the index hospitalization with no subsequent death at 30 days or at 1 year. Further, this data also illustrates the more benign prognosis of patients with STEMI due to SCAD when compared to STEMI due to atherosclerosis. Other outcomes at 1 year that we examined were revascularization, stroke, and MI. There was a numerical difference between revascularization and stroke in those patients with STEMI due to SCAD and the patient with STEMI due to atherosclerosis. However, overall there was no significant statistical difference between these two cohorts. Among STEMI patients due to SCAD, patients who did go under PCI, 7% of them had stent thrombosis, whereas 13% had in-stent restenosis within 1 year. So our conclusions in patients with STEMI due to SCAD, the dissection process often involves LAD, including also left main, proximal or mid-segment, with a consequent severe reduced coronary flow. Urgent revascularization with PCI is successful in most patients, achieving a TIMI flow of 3, 89% of these patients, but often do require an extensive stent burden. So despite this presentation of 19% of patients presenting with cardiogenic shock, survival at 1 year is up to 98%. Our findings do suggest that an aggressive revascularization strategy in patients with STEMI due to SCAD is effective, especially for patients with non-distal dissections. I want to give special thanks to all of our co-authors, Dr. Gray, Dr. Sharkey, Dr. Henry, Ross, Don Gretchen, and Dr. Cantu from Cedar Medical Sinai. Thank you.
Very nice, Angie. Thanks. So how did you identify these patients?
So this is by electronic medical record. Okay. We examined the terms dissection, coronary dissection, spontaneous coronary dissection, and we went through each medical record to see whether they were iatrogenic versus spontaneous coronary dissection.
Okay, so it wasn't through the level 1 database?
It was.
It was?
Yeah.
Okay.
Mm-hmm.
Okay. So I'd also think that there may be more patients out there, and I think it would be worthwhile to just go through that database and find any young women and review their angiograms, because I have a feeling that a lot of times this gets missed. Or
that's what we've been doing. Actually, the numbers have been increasing.
Good. Okay.
Great work. It's a very interesting topic that's gaining a lot of interest out there. I kind of went over a paper that came from Mayo that looked at SCAD patients. Well, I think it were 200 or so patients. About 60% of these patients had underlying FMD. We're able to look at this because I share some of these cases with my colleague cardiologists, and most of the patients that I've seen, we were able to find beating appearance in the renal artery. You know, sometimes the iliac when you enter to do the angiogram. Even if when you do the angiogram, if you don't even see stigmata of FMD, about 17% of FMD patients would have beating on the upper oxygen arteries. So based on that Mayo paper, about 60 to 65% of these patients had underlying FMD. We're able to look at this. The other thing, that paper kind of saw that those patients that went for revascularization had slightly worse outcome than these patients that are treated medically. And those patients usually do really well, as you kind of pointed out in your paper. Thank you.
So to answer the FMD, we do look into this in our database. This will be probably mentioned in our manuscript. There is a prevalence between 40% to 65% of FMD in patients with SCAD. And again, it's very operator dependent. You would need to put in some contrast in the iliac, and some people even argue that maybe the carotids can get the beating appearance. I think this is just starting, and looking for the FMD, it is important because a good chunk of patients with SCAD do have FMD.
Sure. That series in Mayo, they detected 60%. They used CTA to screen these patients routinely. But there's a series in Canada where they routinely did invasive angio of the iliacs and renals, and they found 74%. We do, occasional shots before per close of the iliacs, but we don't routinely do invasive.
And actually, some of the patients that I saw, we found the section of the device too.
I have a follow-up. Actually, I have a clinic patient.
So I'll be very happy to help, by the way.
Yes, please.
Great presentation, Angie. I have a question. Looks like you have a quite significant restenosis rate
Yes.
in this patient population. Do you know if statins were used? There's some data that statins are not indicated in patients with SCAD, especially, so I wonder if you could link those two.
Sure. So, one that you're referring to. So statins right now are just indicated for those patients with dyslipidemia. There's a big paper from Mayo that they looked into this, and they found no benefit using statins when they were not indicated. And I think this is more for recurrent events, because as you age, you gain your cardiovascular risk factors. So what they note in this paper is to start statins only if your patients do have dyslipidemia.
I could just speak, if you, on the angiogram, is the milligram, and it's very operator dependent, you may not see atherosclerosis or small atherosclerosis, but on the CT, a lot of these people do have some atherosclerosis. So it's really dependent on how well you define your investigation. But I would say you would be under the burden of proving that you don't do that. Because almost all these people.
Correct. And the definition of spontaneous coronary artery dissection in angiogram, it's in a lot of debates, because some argue that you should not have any atherosclerosis in order to diagnose SCAD. And others, what they argue is that you should only have a segment, the segment that had spontaneous coronary artery dissection without atherosclerosis. So other arteries may have atherosclerosis, just that segment should not.
The Mayo review related to adverse outcomes, whether, and then so they advised against routine use, but whether that anyway, you know, and,
And we don't know how long, once we saw these patients in a clinic, how long we have to continue that and answer questions. So, but I think these two things.
I think we should keep moving. Great job, Angie. Okay, so the next presenter is Dr. Joe Jensen, who's the second-year internal medicine resident. He's a native of Minneapolis. He went to Notre Dame. During med school, he took some time off and formed a couple of companies during a break between years of med school. And he's now a resident here at Abbott, is interested in cardiology, and has been working with Dr. Miedema. And this is a post.
Thanks, Dr. Harris, for the introduction. First of all, before I get started, I want to thank Dr. Miedema for giving me the opportunity to collaborate with him on this and other projects. Next week will be my first national conference poster presentation out in Anaheim, so I'm very much looking forward to that as well. Using the coronary artery calcium database, we looked at the association of body mass index with coronary artery calcium and subsequent mortality. As we know, obesity has been associated with multiple cardiovascular disease risk factors, including coronary artery calcium. Coronary artery calcium has been shown to be a strong predictor of coronary heart disease and cardiovascular disease mortality. And kind of putting those two thoughts together, it would seem intuitive that an elevated BMI would be associated with a higher risk for mortality. And as a bit more background and a quick review, body mass index is calculated by dividing the weight in kilograms divided by the height in meters squared. And you can see the National Heart, Lung, and Blood Institute standard BMI categories of 18, less than 18 being underweight, 18 to 25 being normal, though there is some room for debate with that categorization, 25 to 30 being overweight, and generally anything greater than 30 is considered obese, so they further break that down into grade 1, 2, and 3 obesity. So one of the main reasons we wanted to look into this study is the fact that previous literature has pointed out an obesity paradox, meaning that people who are overweight actually have significantly reduced risk for all-cause mortality. And the most notable paper for this comes from Catherine Flagel in 2013. And in this systematic review and meta-analysis of reported hazard ratios for mortality, looking at overweight and obese, she looked at 2.8 million individuals and more than 270,000 deaths. And in the end, she showed that overweight people are actually at decreased risk for all-cause mortality compared to the normal weight population. And going further down the table, you can see that even the initial grade 1 obesity category doesn't have a significant difference in mortality as compared to the normal weight population. If you look even further, the confidence interval just barely crosses 1. And it wasn't until you get to grade 2 obesity in the BMI category of 35 or greater that you find a significant risk, an increased risk for mortality. So we wanted to look to see if this held true in our own population. And the Coronary Artery Calcium Consortium is a multi-centered cohort of over 66,000 individuals that are free of established atherosclerotic coronary vascular disease, and that's an important distinction. We looked at non-contrast cardiac-gated CT scan to establish the initial coronary artery calcium, and we included patients with baseline BMI measured at assessment. We looked at mortality through the Social Security Death Index and cause through the National Death Index. And here are the baseline characteristics of the over 36,000 patients that we looked at in our population. A couple of important things to note from this table is that the average age was anywhere between 45 and 65 years, which is a relatively young population. Relatively healthy population as well, with a low prevalence of diabetes and smoking, though this population did have a higher prevalence of hyperlipidemia and a strong family history for coronary heart disease. The majority of this population was male. So first, our results, we compared to individuals with a normal BMI. Those who were overweight and obese had greater odds for coronary artery calcium at baseline. And you can see that increase with the corresponding increase in BMI categories. However, the multivariable adjusted hazard ratios for mortality showed a slightly different story. And we had a median 11-year follow-up with only 1,550 deaths, which represented just over 4% of the population. And as you can see here, there is no significant difference in mortality between the overweight population and the normal weight population, showing no evidence for an obesity paradox. Importantly, for the other categories, BMI greater than 30 was associated with an increased risk for mortality. And you'll notice, too, that we broke down the BMI category slightly differently, and I'll talk about that in a little bit. But looking at the lowest BMI category of 18.5 to 21, there was actually increased risk for all-cause death in that category. So overall, we found that the transitive property doesn't necessarily apply to our population. Despite the fact that people with elevated BMI were at greater odds for coronary artery calcium, it was only in the obese category that mattered for mortality. And there are a couple important limitations of BMI that are worth mentioning. And one is that by itself, body mass index doesn't necessarily accurately depict somebody's metabolic profile. Other things such as fat distribution and cardiorespiratory fitness play important roles. And the classification of BMI is also important. Flagel in 2013 used the standard NHLBI categories, classifying anyone between 18 and 25 as normal weight. However, in chronic disease, it's thought that weight loss throughout chronic disease actually gives a false impression of a healthy BMI, and smoking is also thought to play a role in lower BMI that actually have higher risk for mortality. So in the end, it was no surprise that we found higher all-cause mortality in the BMI population of 18.5 to 21. Others have postulated that higher BMI is actually better in chronic disease because it leads to higher metabolic reserves. If we were to take the obesity paradox as true, one idea as to why it would be true is due to physicians, and that greater BMI would lead a physician to be more aggressive in risk factor modification. So in the end, better outcomes don't have anything to do with increased BMI. Rather, it has everything to do with the physician involvement in that risk factor modification. And again, it's important to mention that our population was young, relatively healthy, and with limited follow-up of over 10 years thus far, we just don't have enough data to know whether or not there would be a difference in all-cause mortality. So it'll be interesting to move forward to see if that data may change. So in the end, we did not find evidence for an obesity paradox, both looking at baseline coronary artery calcium and risk for mortality. Individuals who were overweight and obese were more likely to have coronary artery calcium, but that did not hold true for increased mortality, as only the obese category was at higher risk. So again, I'd like to thank everybody that collaborated with me on this project. I look forward to Anaheim next week, and if there's time, happy to answer any questions.
Is there any difference between the genders and the outcomes based on BMI?
I do not believe there was any difference of breaking down male versus female.
Any other questions? Presentation. All right, our next speaker really deserves no introduction. Maybe that's not the right way to say that. I don't think he needs an introduction. I think we all know who he is. Okay, that's what I was trying to say. Mike Miedema is a graduate of the Abbott Northwestern Residency Program. He did his cardiology fellowship when we were part of the university program. He then went to Harvard and got his master's of public health and did a cardiovascular prevention fellowship at the Brigham and Women's. He recently was honored with the Early Distinguished Career Alumni Award from the University of Minnesota. So that was just announced last week, I believe. I saw it on Twitter. And Mike is presenting. So this is a little bit different format than the earlier presentations. Mike is actually a finalist for the Elizabeth Barrett Connor Young Investigator Award for Prevention. The presentations will be Sunday night, and he'll be, or the award will be announced on Tuesday night. So, Mike.
Thank you. Good morning. Yeah, so this is an oral presentation on Sunday at Anaheim, and so if you have any feedback on the slides or the formatting or anything, I'd be welcome to take it at this point. And so the project we are talking about is an analysis of the two recent statin guidelines. And so last year at AHA in 2016, the United States Prevention Service Task Force, the USPSTF, released their version of statin guidelines for the U.S. So this is for primary prevention, the statin use for primary prevention. And compared to the previous ACC-AHA guidelines, they're a little bit more conservative. And so they recommended for adults age 40 to 75 with you need a 10-year risk of at least 10% before considering statin therapy. And they also put the caveat that they required at least one major ASCVD risk factor. You had to have either hypertension, hyperlipidemia, smoking, or diabetes to qualify for statin therapy. And again, the prior ACC-AHA guidelines use a threshold of 7.5%, so a little bit more aggressive. And you don't have to have one major ASCVD risk factor in order to qualify by ACC-AHA. And importantly, with the ACC-AHA, they put a real big focus on that clinician-patient risk discussion before you initiate statin therapy, just to talk about the risks and the benefits. They aren't making it a strict mandate that they take statin therapy. They just want you to have the discussion with them about the risks and the benefits. So our goal is to contrast these two guidelines. And the prior data that came out shortly after the USPSTF guidelines came out was from N. Haynes, and they looked at just the impact on the U.S. population. And their data suggested that 45% of the U.S. population qualifies for a statin using the old ACC-AHA guidelines, whereas with the new USPSTF guidelines, there's about an 8.5% difference in terms of decrease in eligibility. And say that equates to about 9 million U.S. adults that would suddenly be not eligible for statin therapy if you use these newer guidelines. And so we wanted to use data from MESA to kind of do a similar analysis and really expand on that. And so we wanted to compare statin eligibility between the two guidelines, then also analyze the prevalence of coronary artery calcium in people eligible and not eligible, as well as those with discordant guidelines, so people that were eligible by ACC-AHA but not USPSTF. And then subsequently, we have event rates. So we're going to look at the actual ASCVD event rates in these people according to eligibility categories. So the methodology is relatively straightforward. This is data from MESA, which is a community-based prospective cohort that's really trying to define the prevalence and progression of cardiovascular disease in a multi-ethnic population. It's been sponsored by the NHLBI, 6,800 people at baseline, age 45 to 64. The baseline exam was in 2000 to 2002, and there have been 4 subsequent exams since then, with the most recent exam 5 completed in 2012. Of those 6,814 patients, we excluded 806 because of age. We excluded another 800 because they were on statin therapy at baseline, and then we excluded 184 that had LDL that was above what the guidelines are indicate. Above LDL above 190 is typically considered potential for FH, and so that's kind of a separate guideline. We ended up with 4,962 participants in our study. Statin usage was by self-report, but they also were asked to bring their pharmacy containers with them to the visit, and those were reviewed. And then traditional ASCVD risk factors were defined according to the document released by the USPSTF. We counted people as statin eligible by USPSTF if they had one major ASCVD risk factor as well as a 10-year risk above 10%, whereas for AHA, they just had to have a 10-year risk above 7.5%, or if they were diabetic, you qualify by ACC-AHA. And we list them as potentially eligible if they were in 7.5 to 10% for USPSTF, and potentially eligible if they were 5 to 7.5% by ACC-AHA. So we used the 10-year ASCVD risk, and that was calculated according to the pooled cohorts equation calculator, the PCE calculator, which came out with the 2013 guidelines. That same calculator is recommended for use by the 2016 guidelines. We measured CAC at baseline, and then for event rates, we looked at several different outcomes. We really focused on this hard ASCVD, and that we use that because that's what this equation is modeled to predict, and that's what the guidelines recommend calculating your risk for. So that's the one we really focused on. So for baseline characteristics, the average age of this sample is just under age 60. It was multi-ethnic, as intended by the cohort, with a pretty broad range of risk factors. And important to note, almost a third had more than 2 traditional risk factors, but also 25% had no traditional risk factors, which obviously plays a role in determining eligibility. So a pretty broad range of risk factor characteristics. In terms of eligibility at baseline, we found that 34.4% were eligible according to USPSTF at baseline of the study, compared to 49% by ACC-AHA. It's really a 15% discordance at baseline, so a larger discordance than what was seen with N. Haynes. And over follow-up, for people that remained in the cohort and remained free of cardiovascular disease, the prevalence increased in both groups, but it increased more so by ACC-AHA. By the end, we had a 20% discordance between the two guidelines, so a pretty big difference between the two guidelines depending on which thresholds you're using. If you look at the people that qualify for statins by the guidelines, you can see that people that qualify according to USPSTF in general are older and in general had a higher risk factor profile. But again, you couldn't qualify if you didn't have any risk factors. So 10% of the ACC-AHA cohort qualified despite having no major risk factors. So a pretty high prevalence of people with no major risk factors according to ACC-AHA. If we look at the prevalence of CAC in these people, there's a higher likelihood of CAC in people who are qualifying for statins. So in USPSTF, it was about 33% qualified that were eligible had significant CAC, as calcium scores more than 100, and 28.9% had calcium scores more than 100 if they qualified by ACC-AHA. So not surprisingly, the people who are eligible by USPSTF seem to be a little bit of a sicker population. They're a little bit older, a little more risk factors. And if you look at those who didn't qualify, we see a higher prevalence of CAC there as well. Again, this is a higher threshold to not be eligible. 8% had significant CAC compared to 4% by ACC-AHA. We look at subsequent event rates. These are the actual ASCVD event rates over time now in MESA. And again, as would be expected, the people who are eligible by USPSTF had higher event rates over time. So the people that qualified for statin had an 11.6% event rates by USPSTF, whereas by HA it was only 10%, so a higher event rate. The more interesting part of this analysis, though, is the discordant group, the people who are eligible by the prior guidelines but now not eligible by USPSTF. And so if we look at that group compared to the baseline sample, they're a little bit older. And again, 36% don't have any traditional risk factors, so a high prevalence of having no risk factors. And if we look at their prevalence of CAC, if we take people who are eligible by ACC-AHA but not USPSTF, 50% have a calcium score of 0, and 20% have significant CAC with a calcium score more than 100. And if you look at event rates in this group stratified by CAC, you see they vary pretty significantly. So if you're eligible by ACC-AHA but not USPSTF, and you have a calcium score of 0, their hard ASCVD event rate was less than 5%, which we would consider a low-risk group. Whereas the ones that have significant CAC, their event rate is 13.8%. So marked difference when you stratify by CAC in these people who have kind of unclear recommendations, so to speak. So in MESA, statin eligibility at baseline varied significantly between the two guidelines. We had a 15% discordance depending on which guideline you use, and that discordance actually increased over follow-up. Discordance was more significant than what we saw with the N-Haynes analysis, and that's probably because this population is older and a little bit healthier. So they had a higher prevalence of no risk factors and just are older in general, so they're more likely to qualify by ACC-AHA. Compared to those eligible by ACC-AHA, individuals eligible according to USPSTF had higher prevalence of CAC and then subsequently higher ASCVD event rates. And those with discordant recommendations were 15% of our cohort, of which 50% had 0 calcium. And so their event rates vary significantly according to their baseline CAC, and it suggests that CAC potentially could be of utility in this group as a tool for clinical decision-making. So the strengths of this study are that it's a large cohort, it's multi-ethnic and gender balanced, it's geographically diverse, we have long-term follow-up, and we have data on CAC as well as thoroughly adjudicated ASCVD events. Limitations, we do have some loss to follow-up. The people in MESA are known to have a pretty high rate of preventive interventions that may have affected event rates over time. And then how we calibrate this pooled cohorts equation is still unclear in MESA. MESA is a very modern population. We know that that equation doesn't predict very well in current populations. And so how to best calibrate that equation in modern population is still a subject of debate. I think the fact that we don't have an equation that's very well calibrated to this modern population, as well as the arbitrary nature of these risk thresholds, as well as lack of trial data with CAC, I think those are all reasons why that clinician-patient risk discussion remains important. So in MESA, statin eligibility varied significantly between the two guidelines. People with discordant recommendations had a modestly elevated event rate that varied significantly according to CAC. I think healthcare providers and systems should understand that the choice of which guideline to adopt can have a significant impact on statin utilization and subsequent outcomes at a population level. Thank you.
Great talk.
One thing I don't understand, I started a study that
yeah.
time, and I know that it's done at that time, herbal and oil and all these kinds of and they did all these studies and they said, okay, at some point if you add the calcium score to your risk factor patient, you actually reclassify patients to better. And then these guidelines that come out now, they still don't mention that calcium score, but I mean, when you look at all what you do, isn't it clear by now, or is it just not good enough to say that if you have a high calcium score that you actually put that into your calculation?
Or, on a sense.
And then the other question was, can someone die on the test? So why is it necessary to think about that anymore?
Aren't we helping?
The last one's hard to answer, but the first one, yeah, so there's a lot. The problem with it is that it's all observational data, and so it makes sense. It's very intuitive. Until there's randomized data, I think the guidelines said we're not going to make it a class 1 recommendation. In the 2013 guidelines, they said, calcium scoring can be considered if you're unclear with the decision. But they also included CRP and family history and several other things that you can consider. I think the data for CAC is a lot stronger than it is for those things. In the next round that's coming out in 2018, I think it might be a little stronger of a push for CAC, but until there's randomized data, they probably aren't going to conclude it as, one of the foundations of kind of the prevention assessment.
Great talk, Mike. I think the thing that I was wondering about at the end was, the politics of this are such that you're going to have advocates of each risk score probably sitting in your audience, and so you run the risk of if you come down on one side too hard, you're going to irritate some people. But I found myself wanting a little more recommendation of, so what are you doing in your practice? Do you have which of these guidelines are you using? Are you using coronary calcium? I guess I'd like to hear a little more about how are you taking this and influencing your practice with it, or what would you recommend to someone like me that doesn't keep up with this debate?
Yeah, so if we were to come up with a document for a line and say how should we go about this, I would recommend that if you're 10% or above, you should recommend statin therapy. If you're in that 5 to 10% range, that's really where calcium scoring has the most benefit. And that range, even though it sounds small, that's the majority of our middle-aged population. They come out in that range. And if you're less than 5%, probably can leave them alone, though if there's family history or if there's a risk factor there, it's still reasonable to check calcium in that population as well.
And again, I don't know the politics of the award competition, but I wonder if it wouldn't be a bad idea to say, here's what I'm doing.
That's a good thought. Yeah, I'll give that some thought.
So along the same line, what calcium score will make me change your mind? Is it more than 0 or 0 or 100?
Yep, so we typically use 100 as our threshold. In MACE, at least, that's associated with a high ASCVD event rate over time if you're 100 or more. To me, a lot of patients almost always gravitate towards that age gender percentile. That means more to them than the score, and which I think that just in terms of understanding it. To me, that we know that the absolute score trumps the age gender percentile, and unless you're in that 199 category. So people with just a little bit of CAC, if you're 75, that's fine. That's less than what you'd expect. If you're 45, it's early. To me, that makes a big deal. So if they're more than 100, I treat them as high risk. If they're 1 in 99, that's where the age gender percentile comes in, I think.
All right, great job, Mike. Thanks for coming.